employer will be paying part of the premium. So the premium cost is shared by both. Since premiums are based on group as a whole, the risk is spread out. That means if you are part of a company and if there are some 1,000 employees, the risk of the healthcare cost is shared by all 1,000 people. That's the reason you end up paying a less premium. The policies are often popular type of private health coverages. So most of the private health coverages, that's what they offer. Okay. One of the benefits to group health insurance coverage is that one cannot typically be denied. I think this is very, very important here. If you are part of any company here, I mean, there's nothing like denial. Right from the day one that you join the company, the coverages kick in. But only in some cases, some companies, you have to wait for 30 days or 60 days or whatever the time period is, that, the coverage will not be in immediate effect. But in some companies, it is with immediate effect. So this is an important point that you need to keep in mind, how your coverage will start and if there is a waiting period or not. Okay. Then some more information about it. So there is a group insurance from a non-employer. So employers can offer health policies, and even a non-employer group. For example, if there can be a non-profit organization, or there could be any church groups, so any associations like that. Even they can offer health plans which are not as cheap as your employer group, but at least it's better than having individual policies. So remember that there are other groups as well, who can offer health insurances apart from your employer group. Another couple more types of health insurances that we come across. One is the student health insurance. So any college-going student health insurances, once they reach the age of maybe around 18 or 21, they are not part of your employee or the parent's coverage anymore because they have reached a certain age. But if there are students, if you show as a proof, then some employer groups allow. But in some cases, if they don't allow, then there is a separate coverage for the students. So even a student health insurance is available, and they can get these policies as well. Then there is a short-term health insurance. As I was telling at the beginning, there is an individual health insurance. Similarly, there is a short-term where it is offered only for a few months and the maximum up to 3 years, some plans. So this is only like a short gap arrangement where, in case you are trying for an health insurance or some companies and there is some waiting period, but you need it immediately, what do you do? So there are some short-term health insurances. You can talk to your agent and find it out. So it's like a bare minimum requirement. So not many things are coverages are provided, but at least if you need for namesake some health insurance coverages in case to meet any immediate or emergency purposes, yes, there are some coverages like a short term that you can buy. Okay, so let's talk about this COBRA. COBRA stands for Consolidated Omnibus Budget Reconciliation Act. It's basically a policy, it's a coverage that in case you lose your employment with any company and all of a sudden your coverage goes, right, your no more contract is valid. So what do you do in such a cases? Then there's a program called COBRA. This lets you to continue the coverages that you were enjoying the benefits by being part of the company. That's what this COBRA meant for. So they allow you to keep it for 18 months, but as you said, your premium is paid by your employer as well, right? So that cost you have to bear with it. So that's the catch here. So that means if you are paying like $300 every month when you are part of a company, now if you're no more, but if you want this COBRA, so you have to pay double the premium, that is $600 per month. So that's very lower than I'm saying, but normally if you are on a COBRA, it's pretty much like $800 to $1,000 you will be paying, so it's not cheap. But in case you want the coverage, coverage is available.
Hi, Raghu.
Yeah.
Yeah, like if like they lose job, then like they can keep the COBRA, right? But if they have to pay the premium, so why do they go with the Cobra instead of going for individual healthcare?
I mean, that's your option. I mean, in case you want to have the coverage, yes, you have an option of extending the same benefit. So that's what some people would do. But if you want to quit, if you don't want to opt for Cobra, yes, you can always go with outside other plans as well. So you are not forced to continue the coverage. So it's just an optional.
But in that way, like Cobra seems to be expensive.
Yes, yes. Cobra is expensive. That's correct. I don't know why, but it is expensive because part of the cost your employer was bearing and now you are bearing it. So that's the reason it becomes expensive. All right?
Yeah.
Okay. Some more information. Like there is a qualifying event. That means you are having a spouse or a dependent and who have been included in the employee's health plan. And but all of a sudden, for example, if the employee, there is a death of an employee, so that means the coverage has gone, right? So no more the dependents are eligible for its coverage. So that one event is a qualifying event if in case you need to opt for a COBRA. Then another event is in case there is a legal separation, right? Or there is a divorce from the insured employee. So the kids and the dependents are left out. So for them, the COBRA is available. And in case there is a loss of a dependent status, like if there is an insurance policy holder and there is a loss, yes, the rules will apply. The employee becomes entitled to a Medicare. So I'm a 64 years. Last year to this year I'm 65, and now I'm eligible for Medicare. And whatever the insurance plan that I was before, now the company will not sponsor it because the Medicare is covering now, right? So in this case, so what happens to my dependents? So yes, if they want, the COBRA can be extended for them. And any in the event listed above that causes the employee to lose the health coverage. So that means basically it's telling that there are different events which can happen in everyone's life. And in such a case, there is an option for you to continue the benefits, but at a cost. Okay, so we have seen some different coverages, and now let us shift our topics to the different plans. Basically these are the managed care plans. So we will be talking about. We will talk about these indemnity plans versus managed care. Under the managed care, we've got three types. So we want to talk about the HMOs, PPOs, and POS. Then there is a group health insurance, individual health insurance. I mean, these are the different insurances: a vision, a dental, Medicare, Medicaid, Medigap. So the different types of insurances. But we will mainly touch base on the first two items. So health insurance are broadly into two categories. So one is indemnity plans, which are also called as a reimbursement plan. Then the second one is your managed care plan. So let's talk about indemnity plan. The very word indemnity plan it's like a contract between two parties. That means the contractee is to reimburse for all your medical expenses, no matter what the cost is, and who provides the service. So that means you have a freedom of going for a healthcare services for any physician. That means as long as you have a contract to reimburse the cost, so that's what it is all about. So under this type of a plan, the insurer pays a specified amount for the day. I mean, there can be a contract saying that a specific amount is paid and for a specific number of days, or it could be actually on actuals. Whatever is the cost, is that everything or a percentage of it is reimbursed. So again, it depends upon the cost. So basically, indemnity tells that it's a reimbursable plan. Okay? So there are two types of reimbursements that can occur in this particular plan. One is a reimbursement actual, that means on actuals. Under this plan, the insurance will reimburse you the actual cost for all the specified procedures and the services, regardless of how much the cost might be. So that's as per your contract, to reimburse the actual cost. And the second type of a reimbursement is percentage-wise. I mean, is it 20%, 30%, 40% of the cost? So that means the common reimbursement percentage is 80%, right? That means up to 80% the insurance company will reimburse you. So up to 20%, then it is your co-payment. You need to think that as a co-payment or your out of pocket. So these are the two different types of reimbursement plans within the indemnity plans. Okay. So now let's see about these three types of network organizations. Basically, they are called as a managed care organizations, NCOs. So we'll see the differences between these three. The first one is an HMO. Now, HMO stands for Healthcare Maintenance Organization. It's type of an healthcare system. Basically, it's a group of physicians or hospitals, who have a contract, for the services they provide to the members. So HMOs share a goal of reducing the healthcare costs. Now, since they form a network, the goal is to reduce the healthcare costs and get and provide services at a lower the cost for a member, right? So that's their goal. But how do they achieve their goal? That means they focus on preventive care. So that means implementing the utilization management controls, meaning they encourage you to be part of your healthcare plan, your lifestyle living, healthy lifestyle living, and help you to be part of your Weight Watchers program, something like that, so that you can regularly go to your fitness centers, maintain some good health. Then that will lower your cost. So that's what these HMOs tries to help you out in reducing the cost, right? So the doctors, hospitals, insurance all participate in a business arrangement known as an HMO. Any questions on this? Because we will be talking a lot. If you're on your project, the HMO, and it's important that you understand the meaning of it. So think that it's a network of a physician, and they have a contract. And the very meaning of the contract is to provide healthcare services to its members. And at the same time, they try to minimize the cost by providing all the preventive care to its members, right? So that's the key thing about having an HMO. So the HMOs provide a medical treatment on a prepaid basis. Now that means the HMO members pay a fixed monthly fee. That means if I have a contract, if I have a plan, I'll be paying a fixed premium, to the HMOs. No matter, whatever issue I have and whatever problems I have. So that means I'll be paying on a fixed monthly fee basis. They provide medical services from office visits to whatever it may be. But only thing is the physician has to be part of the HMO network. I think that is the key thing here. So when you join in an HMO, you are a primary care physician. That means you are forced to identify a particular physician, and he has to be designated as a primary care physician. That means you will be going to him for all your medical needs. In case you need to see some other physician, then unless your primary care physician referred, you are not able to see another physician. In case you see, then some of the coverages are not covered. So that's the key thing of being part of the HMO here, right? So let's see some of the advantages here. So low out-of-pocket cost. I mean, that's a basic purpose of having an HMO. The members pay a fixed monthly fee regardless of how much medical care is provided. Instead of deductibles, I mean, there is no deductible here, but you have a co-payment which is very, very minimal. So there is a minimal co-pay. For example, every time you visit a doctor, and there is a fixed monthly fee. The focus is on wellness. I said, that's a motive of HMOs. They always try to, get the reduced cost. So by promoting the wellness and preventive care, and they try to reduce their out-of-pocket costs and also the paperwork. I mean, there is no reimbursement here. I mean, no matter what your healthcare needs are, there is a fixed cost in terms of your monthly payment, and there is no deductible here, and there is a nominal co-payment. So many HMOs offer education classes, because they try to minimize the cost, right? And they focus on wellness, so they conduct a lot of education classes so that you're aware of your health, and they provide you some discounted health club membership so that you can take care of yourself. No lifetime maximum payout. Some of these policies have a lifetime cost. Beyond certain costs like 75,000 expense at all, the insurance companies they don't cover. But here HMOs they cover. There's nothing like a lifetime maximum payout. So managed care, MO stands for managed care organizations. They generally do not place a limit on your lifetime benefits. So HMOs will continue to cover your treatment as long as you're a member. So these are the key advantages of being part of HMOs. So let's see what is the negative side of HMOs. There's a tight controls make it more difficult for a specialist there. I said, right? You need to identify a physician as a primary care physician, and he will be addressing all your health needs. And in case you need to see a physician, some other physician due to some special needs, then your PCP, your primary care physician, has to refer. So the screening process helps you to reduce costs for the HMO. Yes, because they try to educate on your better health care. Care from non-HMO providers generally are not covered. So that means if they are non-HMO or out of your network, they do not cover, or if they cover, there is a higher cost to it. So except for emergencies occurring outside HMO's treatment, HMO's members are required to opt in all treatment for HMOs. So basically, you're tied to a particular physician. To be more specific, so that's a big advantage of a particular HMO. If you're constantly traveling, then you have to see other physicians when you need it. So that's the negative side of having an HMO. The advantages is you're lower the cost, and the negative side is that you're tied up with a particular physician. So that's the key part of HMOs. Any questions about these HMOs? Most of these insurance companies, they perform as an healthcare maintenance organizations. So they provide their products. They have these PPOs also, but all these Blue Cross companies and Aetna, Cigna, they are all HMOs. So let's compare with the PPO. PPO is another network managed care healthcare system where a group of physicians and hospitals, they provide the service to a specific group or association. So your entire group has to be part of these PPO organizations, right? So let's see what the difference between HMO and PPO. The same, they are both managed care organizations. They are same network, but PPO may be sponsored by a particular insurance company, one or more employees. Okay. PPO physicians provide medical services to the policy holders at a discounted rate. They also support utilization control programs to help reduce the cost. Okay. So PPO members pay for services as they are rendered. So we have seen that in HMO, the cost, the member pays a monthly premium as a fixed cost. So, and there is no additional cost involved. But in PPO, members pay the services as they are rendered. That means the employer groups, they reimburse the cost. So that's the main difference between HMO and a PPO. So price for each of our services is negotiated in advance by the healthcare providers. So since it is a network, so the price is always negotiated for all these types of services that is needed. Remember, we have seen some different types of services cost before. For all those services, whether there is a physician visit or if there is an hospitalization or there is a lab, so everything is a fixed cost that is agreed upon by the PPO, right? So those things is negotiated, and whenever there is a cost arises by the policy holder, it has to be reimbursed. So there is some paperwork involved in this PPO. So if you see the advantages, you are free to see any physician within the network. That means you are not tied up to any particular primary care physician. So you can pick and choose any physician who is, as long as he is in your network, right? So if he is part of the network, most of the reimbursements are covered. That means, for example, 90% of your reimbursements are covered if your physician is within the network. Otherwise, it's only up to 60% is covered. So that's the thing that you need to know to what extent the coverages are. And the next thing is your out-of-pocket costs are generally limited here. So that means your healthcare paid out of your own pocket, like deductibles and co-payments are limited here. So that's another advantage here. Typically, out-of-pocket for network care are limited to, like, for example, 1,200 for individuals or 2,100 for families. I mean, these are just the numbers, but again, it could vary from plan to plan. Out-of-pocket costs for non-network are typically high, than within the network. For example, it could be like $2,000 for individuals or $3,500 for families. So the main difference what you have seen is one is there's freedom for you to pick and choose your healthcare provider, and the second thing is there is reimbursement involved on the cost that is incurred for your health service. So the disadvantage is your less coverage for treatment provided by the non-PPO, by the physicians. The more paperwork and expenses than HMOs. So that's the negative side. That means you need to keep track of all your receipts and bills and then get reimbursed for your healthcare costs. Okay. So there are some advantages and the disadvantages of being part of the HMO and also on the PPOs. So one is the freedom, and then another one is on the reimbursement or some administrative work, basically. The third one, so let us talk about this point of service is another plan. So the insurance companies, what they have done is, once they came up with HMO and the PPO, they wanted something that is in between. I mean, the best of both the plans. So that's where this POS came up with. So its characteristics have HMO and as well as the PPO. Like HMO, you pay no deductible and usually a minimal co-payment. So that's the best part of having HMO. So that component is put together in this POS plan. And also, you can pick and choose your primary care physician. Right? So zero deductible or minimal co-payment, and then the choice of your primary care physician. So all those good things are available in point of service plan. So any questions so far, the differences between these three? So the advantages of plan are the maximum freedom. That means you can pick and choose the physician, the minimal co-payment. So just like HMO where there is a zero deductible, but the co-payment is very, very minimal here. Zero deductible here as long as you are seeing the physician who is within the network. So that is the key thing here. So there is no good gatekeeper for non-network care. That means if you choose to go outside the POS network for treatment, you are free to see any doctor or specialist. So that's I think a very, very good feature of this point of sales plan. And out-of-pocket cost limited, healthcare paid out of your own pocket are typically limited here. So as long as they are within the network, you're covered. Otherwise, they are higher side. The costs are on a higher side. So on the disadvantages of the POS plan, the point of sale, the substantial co-payment for non-network care. I mean, as long as you are within the network, you are covered, but as long as you are out of network, your costs go up. Deductible for non-network care. In most cases, you must reach a specified deductible before coverage begins for out of network. So there are some disadvantages of being out of network. The tight controls to get specialized care. As in HMO, you must choose a primary care. Your PCP provides a general care and must be consulted. So in that way, you're tightly monitored here. So we have seen some different coverages and different plans here, and I want to introduce your more commonly used terms here, like the provider. Then we commonly use the word payer, and we use the NPI. So there are more terms, but in every session, I want to introduce some terms so that you get familiarized throughout this course. Before I go into these terms, I want to give an opportunity to ask any questions and what do you think so far, the topics, and want to make sure that, you are able to understand. I know the concepts are kind of a very, very common here since everyone is familiar with their auto insurance and health insurance, and we have just started with some common fundamental and basic concepts here. So the moment we hear the word provider, so what do we understand by the word provider? So it's a healthcare provider. He can be an individual, and there could be a group of physicians. It could be an organization. It could be a major hospital or health services or supplies. This particular individual physicians or other practitioners or institutions, or it could be labs, it could be nursing homes, it could be organizations. Anyone who is involved in providing a healthcare service is called a provider, basically. So this does not include healthcare. Anybody who is working as a part of the industry workers, like an administrative work involved in billing, etc. They are not called as a healthcare providers. So they are assisting like an administrative staff, but not healthcare providers per se. The healthcare provider is a person or organization that provides healthcare or medical services for pay, right? So that's what is the exact meaning of a healthcare provider. So in short, we simply say there's a provider. That means whenever there is a provider, that means he provides the service. And how does he get paid? So these are the forms that he fills in. So there is a CMS 1500, then there is a UB04. These are the standard and the name of the forms that are used to claim the reimbursement cost. So CMS is for your professional claims, UB04 is for your facility or institutional claims, then ADA is for your dental, and NCPDP is for your drugs, pharmaceutical claims. So that's what it's meant for. Okay, then the payer is all your insurance companies. This refers to entities other than the patient that finance or reimburse the cost of your health services. These insurance companies are the ones who provide the reimbursement, right? So they are called the payers. So payer organizations focus on managing the gap between the funding and the medical costs. The reason they are using this term is with your phones, I think some of you, thank you. Here we are talking about Medicare and Medicaid. That means the CMS, whether it is a federal government or a state who is sponsoring the Medicaid, they're the ones who are filling they are the funding in order to bridge the gap between the cost and the funding. So that's the reason they are the payers, and also who will be constantly establishing a regulatory environment, whether it is at the state level or at the federal level. So they are the payers. Another term that we want to talk about is NPI. This is commonly this, and actually it has become a mandatory field. When we are communicating any health-related business transaction, it stands for National Provider Identifier. In short, it's called NPI. Basically, it's a unique identification, for all those healthcare providers. So it can vary from 8 position to a 10 position. So it's basically a numeric, alphanumeric, 8 to 10 positions. And there is some check digit at the end so that, you can avoid some keying errors. There's some algorithm that determines the check digit. Those details we don't have to go in. But remember that NPI is a unique identification number that identifies the healthcare providers. And it could be, the length of it could be from 8 to 10 positions. So who issues it? So NPI is issued by an organization called National Provider System. it is the one who maintains like a database of all the NPIs. So it gathers the information and maintains and provides those who request for it. Okay. So NPI can be at a physician level, or it can be at a hospital level or a group level. So, but every healthcare provider should be having an NPI. That means it's the unique identification number. So what are the uses of NPI? So these are some of the areas where we'll be using the NPI in our transactions. Healthcare providers to identify themselves in the transactions. So what are these transactions? So transactions are like, generating a claim. So claims is a transaction. And if you are sending the remittances or you're making a payment per claim, then that's particular transaction. And if you're asking for an information about a membership or an enrollment, that is a transaction. So any communications on the healthcare that happens between the healthcare entities is called a transaction. And those transactions should be identified by an NPI for that particular healthcare provider, right? So that's the reason we are saying healthcare providers to identify themselves in healthcare transactions. Then healthcare providers to identify other healthcare providers. For example, I have a medical insurance with the Blue Cross, but I have met with an accident and there's another insurance company is also involved. That means the other party's insurance is paying to some portion of the cost. So when my insurance company is communicating with other insurance company, then they have to identify themselves, like Blue Cross, what is their NPI is, and also the other party who is involved, their insurance company's NPI. So that's the reason. So we need to identify the insurance companies with their NPI. Then healthcare providers on description. Then health plans to coordinate benefits. So this is whenever they are coordinating the benefits, they need to identify the NPI. Healthcare clearinghouses in their internal files. So clearinghouses are another entities. Basically, they are aggregators. They receive the claims information and then they pass on the information to the providers or to the payers. So they are in the middle who get the information, monitors, tracks them, sends the information to the compliance check just to make sure it is in compliance with the HIPAA guidelines, right? So they are the clearinghouses. So even they have to be identified in all these business transactions. And the electronic patient record system, in the medical record system, so these NPIs are used. So these are the different various uses of the NPI. So it's very, very significant that every healthcare provider should be identified by an NPI. Now we will talk about some of these standards for EDI, the EDI transactions. So I said that a transaction, what is a transaction? In our common banking terminology, a transaction means it's like an event, whether you are making a deposit or you are making withdrawing some funds, so that's a transaction, right? So similarly here in the healthcare domain, a transaction is referred to like a business document. But what does it contain? So it does contain an event or a fact about a claim or about health exchange of health information. To be more specific, that means whether you are sending a claim or receiving a claim, you are making a payment to a claim, you are asking for enrollment information or any clarification, or you're responding or you're acknowledging, any information about a health information is being passed from an entity to an entity, by a covered entity to an entity. Such an information is called a transaction, right? So every transaction has got a format, and that particular format is called a HIPAA standards. So there are some standards. Those standard numbers are called X12 837 per claim. And similarly, if you are sending a remittance, it's called 835. So they got some numbers that will identify the transaction. So we will see in our next slide what those numbers are. So what I'm saying is these transactions, how they are generated. They are generated by the EDI. EDI is nothing but a system or a software that a provider and a payer have to implement in order to generate an EDI standard. That means electronically exchanging the health information is called EDI. And there are some standards, EDI standards. These standards are nothing but your 837, 835, and 834, etc. So we'll be seeing what these standards are. So this list is kind of telling you what these standards are. I mean, there are more standards here, but just for our understanding at this stage, I have listed some of them. For example, 837, when we get onto a project, people will be just talking about 837, they will be using these numbers. So whenever you hear about 837, just remember that it is the claims information. That means who sends this claim information, who receives this claim information, what does it contain, what is the format does it have, how do you interpret it. So all this information is contained in this particular claims transaction, right? So, for example, there is a hospital that I went to a hospital, right? But it has to reimburse the cost that they have provided to my health. So what they do is they generate a claim. So it's always a hospital or a doctor's office who generates the claim and sends it to the payer. That means the provider sends a claim to the payer, and the payer is the one who pays the claim. So there is information about the transaction 837 goes from a provider to a payer. That is called a claim. And when the claim is adjudicated, that means when it is passed for a reimbursement, this particular fact that a claim has been generated, a member has been provided a service, and the cost has to be reported to the state agencies and the federal agencies. Not all plans, but only the government plans will be reported to the states and federal agencies like Medicare and Medicare. And the information that is reported after the fact of the claim is called an encounter. So this is the difference between a claim and an encounter. Once again, a claim is a healthcare event where a member has received the healthcare services, and for that healthcare services, the provider is seeking the reimbursement of the cost, right? So that information is called a claims information. And that information is sent or generated in an 837 transaction. And the same 837...
Hi, Ramu.
Yeah, tell me.
How did provider submit the information to federal agency? Like, is there any software, or like, do they do it through website?
Right. Yeah, actually the details of this EDI will be covering in our second day or a third day. But for our understanding at this point of time, each and every provider or a payer should have a software that can generate these transactions. It is called EDI system. The name of the system is called EDI. That is very, very generic. So there is nothing like a software called EDI, but the system or an environment is called an EDI. That means a system that can generate these transactions in an electronic format and send from a provider to the payer, and vice versa too. They should have a software that can interpret, that can receive the electronic transactions, interpret them, and then convert into a native system. So this is called an EDI environment. So every payer, every organization, a covered entity, whether it is a hospital or it's a doctor's office or it's a clearinghouse, everybody should have this EDI environment in order to interpret, send, and receive the transactions. So it is an EDI that generates the transactions. Did I answer your question, Kunal?
Yes.
Okay. So we will be talking about that more, this even as the architecture of how an EDI works, how the transactions are generated. So we will be talking about it probably in our next or third session. So we talked about the claim and encounter. Then there's a transactions called 270 and 271. Basically, if I have to submit some inquiry, like I want to know if the members, some information that was not clear, and it's basically the providers will be asking the payers, the hospitals will be asking the insurance companies. So in order to ask, it should be in a proper format, proper HIPAA compliant format. It's called EDI transaction. That transaction is called 270. And when the payer, the insurance company, is receive these 270 transactions, and when they provide a response to it, that response is called 271. And similarly, there is status inquiry and a response. So status inquiry, anybody can send it, right? For example, the hospital has sent a payment, has sent a claim for a payment, and it's 3 weeks gone, 4 weeks gone, 1 month has gone, they have not received anything, and they need to send a status of a particular claim. So then 276 is the transaction they would be using to ask an inquiry. And when the payer, like a Blue Cross or Cigna or Aetna, when they respond back, they will be using a transaction called 277. So this is the same reason that every provider and a payer will be following a consistent transaction in the same format, no matter what. So this is the usefulness of implementing the HIPAA transaction healthcare industry-wide. Similarly, there's a referrals and a prior authorization. We talked about, when we are talking about HMO, we talked about authorization. That means we always see a primary care physician. In case we need to see some other physician for special surgeries or special services or healthcare needs, then we need a referral or we need a prior authorization from the insurance company. Then 278 transaction is used in order to communicate this particular or seek permission to provide the services by the provider. Then there's a healthcare payment. Like we talked about claims that use 837, right? That means you ask for a reimbursement. But when you receive a reimbursement, the payers would be using 835 transaction to send a reimbursement. Okay, then there's a claims attachment. So claims attachment is just nothing but providing some additional information about the claim. So always a claim can have, like a 237 can have a 275 attached to it, or on an ad hoc basis, there can be a separate transaction 275, or when an insurance company is adjudicating a claim, that means when it is going through a different stages of a claim, and if it is not able to adjudicate because of a lack of adequate information, then the payer asks the provider to provide some more details about it. So then that's where the provider will provide some attachments. Let's say, for example, the X-ray reports or blood work reports. So they would send us an attachment in the form of a transaction called 275. So these are some of the transactions. There are a few more, but just for our understanding, we want to discuss them. But we will thoroughly go through in detail, in-depth detail about the 837 transaction and also 835 transactions, so that you become familiar with these. And in most cases, 80% of the cases, you will be dealing with 837 transactions because it is a claim. There will be n number of claims, high volume of claims, and any BA role would certainly deal with the claims. So we will have an in-depth discussion on that. So I think this is what I intend to cover this evening. And now I will open the session for our questions, doubts, concerns, anything for what you heard so far, and if you want some more explanation. And so feel free to comment.
Hi, Robert. This is Angela. Okay, I understood a lot on this health domain, but I was wondering what's the role of business analyst on this? What business analyst is supposed to do?
All right. The business analyst can perform several roles here, depending upon the project that he gets assigned. For example, if he is placed in a hospital environment, for example, so there is a patient accounting or a patient administration or a medical records group, or there could be some upgrades going on. Like I said, ICD-10 upgrades going on, right? So these are the different teams that they can be part of it. But what they would do exactly, as a business analyst, the very purpose of his role would be to understand the business case and the project charter, what is his objectives, goals are. And depending upon them, you need to, ultimately the business analyst role is to define, gather, and get the sign-off on the requirements. That's the key role, no matter in which team he is. So to get the requirements, we need to work with, for example, if he is part of the patient accounting, we need to work with all the claims, to generate the claims. And when they receive the payments, then you need to work on the remittances. That means 837 and 835. So to identify what the requirements are, who is generating it, what are the different plans are there, and when we are receiving it, what are the different plans, like the Medicare, Medicaid, and who are the payers that we are receiving it, and those are the patient administration, patient claim side. If you are on a patient administration side, that means the patient arrival, you're scheduling it, and the various departments of an hospital, and all their online applications or inquiries. So you'll be working to gather the requirements and making any changes on them. So it could be on the batch processes, it could be on your online processes that we'll be working on it, right? So it's basically your patient accounting, patient scheduling, and discharging. So all this comes under patient administration. And then let us shift towards the payer side. If you are part of any health insurance company, and there could be like processing the claims, that's the main area, and sending the encounter. Again, there's another side of the claims that you are sending the information. The third point is if you are part of your testing team. Nowadays, there is a 40-10 versus 50-10 conversion that's pretty much happening in the entire healthcare industry. So as a business analyst, you will be analyzing the 40-10 format, try to understand what are the gaps are, and see how to fill those gaps are. So you need to perform those gap analysis 40-10 versus 50-10. That means that you need to understand the 40-10 format, then you need to understand the 50-10 format, and you need to identify the gaps. So that's the primary role of a BA. And in most cases, the BA also performs the role of a tester, meaning they have to write the business use cases, convert the business use cases into the test cases. That's another role of a business analyst. Third part is if you are on a kind of a data warehouse, every healthcare industry has a big, huge data warehouse. So there are some, most of the data comes from the vendors, right? So when the data comes from the vendors, it is not in a proper format where the data warehouse system can really absorb that and update in the system. So again, you need to understand what is the format in which we are getting from the vendors, and what is the format that needs to be really accepted by the data warehouse. Then in between, you need to identify what are those data elements, what is the changes that you need to make, meaning what is the data manipulation that you need to make. That is a whole part of the data warehouse project. So it could be on the testing side, it could be on the analysis side, on the claims processes. If you are on a product administration, then you'll be talking about your plans, your groups, then your enrollment eligibilities. That's another side which a BO will come into place. Then if you were working with the facet team, then you will be trying to understand the main features of the facet, and basically the BA will try to understand when he is working with the claims administrators, what are the different ways in which a claim the data about the member can be modified or updated or created in the facet. So there is a different variety of roles in which a BA can perform, especially in the healthcare industry. Did you get an idea?
Yes, thank you. That's clear now.
All right, good. How about others? So,
Hi, Raghu.
Hi.
I have one question. Like most of the universities, they have their own hospitals, and they also provide. They also work with the federal agencies for Medicare and Medicaid. So, like as a whole, like how we group them? Like they are a provider or the payer?
They are the provider, or what was the second term you used?
Payer.
Like a PER, payer?
PAYER, payer.
Oh, payer. Okay. Yeah, definitely. For example, if you are working with a Medicaid and a Medicare plan, the state is a payer for your Medicaid, and CMS or a federal agency, they are the payers also, right? So they are the payers, and if you're working on any other commercial product, for example, Blue Cross will be your payer. So certainly you'll be working with the both. You'll be working on the payer side, and you'll be coordinating with the payers. Especially you'll be working with the finance department of these payers. And if you're working on the EDI transactions, then your EDI to EDI, you'll be constantly coordinating to make sure that you're getting the data, or the data is really, sometimes there are a lot of duplicate data, the claims data that are coming in, or you didn't even get the file. So there are several issues that you will be pretty much on a daily basis, you will be coordinating these claims, with the payers. And not only with the payers, but also with the clearing houses. I said clearing houses their role is like an aggregator in between. They receive it, massage the data, and then send it to the providers, right, or the payers. So you'll be working with the clearing houses, the payers. Yeah. So the answer is yes.
Yeah, so I'll give you an example. Brown University, it has its own hospital, and they have this plan that they work with the federal agencies for Medicare and Medicaid. As a hospital, they provide services. So as for the Medicaid and Medicare, so they are the clearing house. What I'm saying is as they work with the federal agencies, because federal agencies are the payer, right?
Yes.
Yeah, but hospital is the provider, but they are not the hospital. They are the part of the plan. Like they provide health insurance plan for the local people also. So I'm talking from the government perspective. So from the government perspective, they are the clearing house.
No, you are a clearing house, in my opinion. You are working with the hospital, right? So your role is like a clearing house.
Mm-hmm.
And the government is the payer for you. I mean, for you, the payer is hospital, and government is a payer for the hospital.
No. What I'm saying is Brown University has its hospital, right? That's a provider, but
yes,
they have their own health insurance plan, like Blue Cross Blue Shield, or that type of organization. I forgot the name. They coordinate with the hospital also, but they provide the healthcare plans to the local people also, and at the same time they coordinate with the Medicare and Medicaid also. So what I am saying is they are acting as a payer for the local people like me, but if they are working with the Medicare and Medicaid, are they this clearing house? Because they are not the provider, because provider will be the hospital, but they are in between. So are they the clearing house for the government?
Yeah. Actually, they are in the middle, right? So definitely they are performing like a clearing house.
Okay, because most of the universities, they have this type of infrastructure.
Yes, exactly. Yep, they have their own healthcare systems. That's right. Yeah. All right. Any other questions? I've seen some Aparna also on the list here. Any questions, Aparna?